Hi. Can you hear me? Yeah. Good morning. I'm very, very happy to be here and to talk about a project that's easily the most rewarding and impactful that I have ever worked on. About several years ago, probably about 6 or 7 years ago, Dr. Love approached us at USC and asked if we would help with her NIH grant. It was an ultrasound project to identify breast cancer in women with palpable lumps in remote areas in Mexico. The project is called AI-supported ultrasound triage of women with palpable breast lumps. Dr. Wendy Bird is a primary radiologist on this study, and I'm presenting all of her work today. It was just an absolute honor for me to be part of it. Sorry, not very sound. Oh, okay. I'm going to start with giving you a brief background on breast imaging. As you all know, mammography is the gold standard screening test we have for breast cancer. It's also used for diagnosis. Uses low-dose X-rays. Most women who get a mammogram get two views, median level oblique view, which is the MLO view, which compresses the breast from side to side, and the CC view, the craniocaudal view, which compresses the breast from top to bottom. Black is fat on the mammogram, white is glandular tissue. Breast masses, both benign and malignant, appear white on the mammogram. Every woman's mammogram is classified into one of these four density groups based on the amount of glandular tissue or white you see. So a woman with a fatty breast, mainly all black, has 0 to 25% glandular tissue. A woman with scattered has 25 to 50% glandular tissue. A woman that's heterogeneously dense has 50 to 75% glandular tissue. And a woman that's extremely dense has greater than 75% glandular tissue or white on the mammogram. How cancer shows up on the mammogram depends on breast density. It's very easy to find a cancer in a woman with fatty breasts and much harder to see one in a woman with dense breasts. And that's where ultrasound comes in. Ultrasound is invaluable in evaluating women that are symptomatic, so women with a palpable lump or nipple discharge, and it's also used for women who have an abnormal screening mammogram and come back for additional evaluation. Again, ultrasound is an important adjunctive procedure. We use it to identify and characterize all palpable lumps, no matter what the mammogram shows. It's the first test we do in a woman with a palpable lump who comes in under 30, lactating or pregnant. Initially, when we first used ultrasound breast imaging, we used to just use it to tell the difference between a benign fluid-filled breast mass versus a solid mass. Now we use it to differentiate between benign solid masses and and malignant solid masses. Of course, our turn for professional pictures was during COVID, but we went anyway. Here I am doing an ultrasound on a patient with my colleague, Dr. Lee. In that picture over there, I'm holding a transducer, which is a probe that we place on the breast in the area that we want to look at. The transducer sends sound waves through the breast tissue, and depending what's in the breast tissue, it'll reflect back echoes, go to the computer, and give us an image to look at. Just some technical aspects. Depending on the part of the breast you're looking at with ultrasound, the transducers vary. So for the breast, we use a linear array, frequencies between 10 and 15. Patient positioning is important. As you saw in the prior picture, the patient's lying down with her arm up over her head. Scanning, documenting lesions, and reproducibility are all very important. Whenever we see a breast mass, we always take two pictures. We hold the probe in the vertical longitudinal orientation and one in the transverse or horizontal. And we take calipers to measure the lesion. So again, whenever we see a breast mass on ultrasound, we take 2 pictures at 90 degrees angles. Normal breast tissue, here you have the skin. The subcutaneous fat on ultrasound is black. Glandular tissue is white on the ultrasound. In the back of the breast, there's an extra fat layer that's black, and then it lies on the pectoralis muscle. Okay, and the woman with the normal fatty breast is black on the mammogram, and the same thing on ultrasound, black as well. A woman with extremely dense parenchyma, all white on the mammogram, is similar on ultrasound, mainly white heterogenic material. Ultrasound is very good at classifying different lesions that we see. A cyst is a benign mass, it's oval, with good borders. A fibroadenoma is a solid benign mass, again, oval mass with good borders. Cancer is very ugly on ultrasound, very irregular in shape, and hypoechoic, darker than the surrounding fat, and glandular tissue is normal, echogenic and bright. So most breast lumps that are palpable are either benign cysts, benign fibroadenomas, or cancer, and they usually all appear white on the mammogram, and ultrasound is very distinct and shows us what these lumps are. Fewer than 10% of palpable lumps represent malignancy in women under 55, and many studies have shown that ultrasound is very sensitive in identifying what palpable lumps are in women, more so than mammography in women under 40. Here's a simple cyst, benign, easily seen on ultrasound, and easily very distinct. Solid mass on ultrasound, oval in shape, hypoechoic, very regular, easy to identify. And here's some pictures of cancers, which are very ugly, irregular, hypoechoic, dark on ultrasound, very irregular in shape and poor margins. Again, another cancer, very ugly on ultrasound, very distinct in appearance. Whenever a person comes in with a palpable lump, we put a BB on the skin over the mass and do a mammogram. Here we see a white mass under the mammogram. We don't know if it's a cyst or solid. We need the ultrasound to tell us what it is. This woman came in with a lump. We put a BB on it. The mammogram just shows breast tissue. Ultrasound confirms that it's just normal breast tissue with no mass. Another patient here, a 27-year-old, comes in with a palpable lump. You see that white mass on the mammogram. We don't know if it's fluid or solid, and it's an ugly cancer on ultrasound. A woman with extremely dense breasts, we can barely make out the mass or the borders of it. Ultrasound shows this is a very ugly cancer. So that's why we were very excited to work on this project for Dr. Love, because ultrasound really is essential in diagnosing palpable lumps. So we can offer this to women in remote areas of Mexico. That's really a wonderful service we're doing for them. Breast cancer, again, has the highest incidence rate at 2.1 million women diagnosed in 2018. Breast cancer is more common in young women in developing countries, and the percentage who die from breast cancer is much higher, 3 times than what we see here. Screening is now well supported in the developing countries. Breast cancer most commonly occurs as a palpable lump, and women under age 50 are overrepresented. In most women either present with locally advanced cancer or a palpable lump. Most of the palpable lumps, 80 to 90%, are benign. So it'd be great if we can diagnose this with an ultrasound early on, so we can use the resources for women who do actually have cancer. Recognition of symptomatic breast cancer in early stages is a priority for the Breast Health Global Initiative, and the Mexican government understands that cervical cancer has significantly decreased in mortality from 1980 to 2010, where breast cancer has increased because there's no infrastructure finding the cancer early in women who have palpable lumps in Mexico. So this project is taking a low-cost portable ultrasound machine, using a minimally trained person to take it to Mexico, take images of a palpable lump in women in Mexico, and use artificial intelligence to figure out if the mass is benign or malignant. There are 4 parts to the study. The first is to create an AI that works. Then the ultrasound validation, which is where we at USC came in. Then we took it to a training site, and then finally we tried it on several hundred people in Mexico. So let's back up. Okay, so basically an easy-to-use portable ultrasound system. Then you put the image in with the AI. The AI says, okay, clearly benign, clearly malignant, or probably benign. So AI is a little tricky. Basically, artificial intelligence is telling a computer how to think and learn like a human, to decision make and problem solve. So in this instance, we're telling the AI, look at these ultrasound images and differentiate benign from malignant. And machine learning and deep learning are part of AI. With machine learning, we're giving clues to the machine. We're saying, okay, if it's oval in shape and it's got good borders, it's likely going to be benign. If it's irregular in shape and spiculating borders, it's more likely to be cancer. Deep learning is when the machine itself figures out the difference between benign and malignant without any help from us. So the AI that we used for this ultrasound was over 700,000 images of benign and malignant lesions were put into the AI system from 40 different clinical sites, all different makes and models of the ultrasound machines, and a wide variety of transducers. So now we're going to test it. Does the AI system work on palpable lump images of ultrasounds? So they came to USC, and what we did was we recruited about 200 patients, combining USC and Harvard, UCLA, and each person with a palpable lump got an image from each of these 3 different ultrasound machines. Then we gave it to the AI to decide which are benign, which are suspicious, and it did a fabulous job. The AI triage performance was 100% sensitivity, 78% specificity, so it correctly identified 78% of the women who did not have cancer. So now we were ready to try this in a training site in Mexico. And so they went to a training site in Mexico in Guadalajara, and the trainees using the portable V-scan was the second year medical student, OR nurse, and gynecological intern. So basically they had found 33 women with palpable lumps in 2.5 days. And they had 3 different scenarios. One was scanned by so each person was scanned 3 times. One's by the radiologist using a big ultrasound machine. The second was the radiologist using a small V-scan portable. And the third was the trainee using the V-scan. So we wanted to know, was the image quality adequate for the AI analysis? And were the images collected by the trainees comparable to those collected by the radiologist? Here's just an example of the AI. You see suspicious for biopsy, it's irregular in shape, and the one on the right, which is benign, no biopsy necessary. So the results were fabulous. Yes, the image quality was adequate for AI analysis. Yes, the images collected by the trainees compared to the radiologists were adequate for analysis. So the AI triage was able to differentiate suspicious lesions from benign lesions equally as well in images from the trainees and the radiologists. And some comments. The device was easy to use and could be really important for the population we serve because it allows us to identify many lumps. I thought it'd be hard to learn how it works, but it was easy. It really does look like a cell phone, but with the menu and the arrows, it was pretty clear. It also makes you more confident to know you don't have to come up with a diagnosis by yourself without help. And comments from the patients. I hope this is something that can improve or facilitate our care. I'm doing this for us, for all women. Imagine living all this time with the uncertainty, the nervousness that it may be bad, and the knowledge that there can be risks when you have to wait so long for a test. So the next step was taking it to Mexico and trying it on hundreds of patients to see if the low-cost portable ultrasound machine with the AI could accurately identify the palpable lumps in women. So they tried to enroll 500 women with at least one palpable lump from 2017 through 2021 in 2 hospitals in Mexico, one in Jalisco, one in Tijuana. I think the Tijuana site closed down early on because we couldn't get the data. For each patient, images from the V-scan, the portable little ultrasound were taken, orthogonal images with calipers. 376 women were scanned by a radiologist, 102 women were scanned by a non-physician research coordinator trained in the V-scan using a validated 30-minute PowerPoint. Then all the women were scanned by radiologists using the standard of care ultrasound machine and given a BI-RADS assessment by the radiologist. So if a lump demonstrated normal fatty tissue or dense fibrogranule tissue, no images were obtained. But if there was non-palpable masses adjacent, then these were documented on both ultrasound systems. For each breast mass, the radiologist collected a bunch of information, age, race, ethnicity, whether it was palpable, the maximum diameter, and gave it a BI-RADS. Did the radiologist think it was negative, benign, probably benign, or suspicion for A, B, and C, depending on the degree of suspicion, or BI-RADS 5, which is highly suspicious for malignancy, and he also described the lesion. Let's go back. Okay, paired images from the V-scan and the standard-of-art Hitachi machine were all de-identified and processed, and the AI software was applied to these images. The AI-generated output, benign, probably benign, suspicious, and malignant. It also gave a number between 0 to 1, giving the risk of malignancy. And a false negative is when we missed a cancer. And we started out with 478 women, 1,216 lesions. Number of exclusions occurred, so the final analysis was with 300 women and 758 breast masses. And the final analysis was 758 masses and 300 women. And there was a sub-analysis with only using a single mass per participant. We prioritized the palpable lumps first, palpable masses first, and malignant one if there was more than one palpable. And for all malignancies that were benign and probably benign by the AI radiologist, Dr. Berg, Wendy Berg, looked at the images. Our results show that the average age of the women was 50 years old. The largest diameter of the masses was 13 millimeters. 56 of the 758 were malignant. And 11% of the palpable lumps were malignant. And among the 56 cancers, 89% were invasive ductal and 11% were DCIS. And for the 300 index lesions, 49 were malignant. And here we show a table showing the performance of the AI on the standard of care images versus the AI in the portable, and then the radiologist assessment. And the AI standard of care accurately classified 53 of the 56 malignancies for a sensitivity of 94.6% and accurately classified 78.9% of the benign masses. Here at the area end of the curve for the AI standard of care is 0.95 compared to the radiologist, which is 0.983, which is really great. And here's a graph of the same thing, true positive, false positive, the ROC curve. And we see the standard of care for the AI with the standard of care shows an AUC graph of 0.95. And for AI in the B-scan shows area under the curve of 0.918. So what's important here is that the AI applied to the images by the radiologist standard of care was nearly equivalent with the AUC and sensitivity as to the AI applied to the portable V-scan images. Here again, the area under the curve and sensitivity for the AI applied to the standard of care big ultrasound machine were comparable to the AI area under the curve and sensitivity with the AI portable V-scan. The specificity for the AI standard of care ultrasound for the radiologist was 78.9%. However, the specificity with the V-scan was a little lower at 48.4%. So it accurately predicted 48.4% of the benign lesions. False negatives on AI, there were 4 malignancies that AI missed. Each of these was a circumscribed oval hypocove mass. Most were DCIS, so it really wouldn't impact the patient outcome. Here's an example of a 37-year-old. She had a palpable lump. The top is the V-scan images, which were incorrectly read out as benign, probably benign. And the standard of care image on the lower shows a more irregular mass, which was correctly read out by AI and the radiologist as suspicious. Operator dependence was an issue. So area under the curve was significantly better for the V-scan images obtained by the radiologist than for the V-scan images obtained by the minimally trained research coordinator. All that tells me is we have to train her better than a 30-minute PowerPoint. I mean, I'm sure just one day of doing ultrasound on palpable lumps she'll have it nailed. Here, comparing the 2 radiologists versus the minimally trained observer, we see all the numbers. The AUC sensitivity and specificity were much higher for the radiologist image than the minimally trained coordinator's images. So again, it just takes a little bit more training. So using the portable V-scan ultrasound images in AI, 33 to 52% of the women with benign breast lumps corresponding to masses on ultrasound could have been triaged remotely with a high negative predictive value. Use of AI is much more easily implemented than having to train a doctor or a nurse on how to read the ultrasound images. It was reassuring that the radiologist could obtain diagnostic images using both the low-cost portable V-scan and the high-end ultrasound machine. Limitations, the V-scan that we used was never FDA approved. So in the beginning, when we were throwing 700,000 images into the AI to teach it how to use, we didn't have any of the images from the V-scan. So now that it is FDA approved, we can throw in those images and really improve the AI software. And also, it's already updated. So the ultrasound, the V-scan probe is much better, is a better transducer with a higher frequency. So I'm sure the images have better resolution now and can also improve the specificity. The radiologist numbers were really high, 100% sensitivity and 87% specificity. And this was, I think, probably one of the factors is that we didn't have follow-up on the BIRAX 3 lesions that did change and were never biopsied, and we didn't have follow-up on a lot of the benign findings. The V-scan interpretations were not recorded by the radiologist, so we weren't able to compare, okay, what does the radiologist think of this V-scan image compared to the AI? What else? We didn't include patient age, risk factors, and other physical findings when we were making our decisions on the level of suspicion to biopsy or not. And we excluded lymph node skin lesions in normal breast tissue, which the AI has not yet been trained on. Whoops, done this. Oh, here we go. So, let's see. Okay, so in conclusion, the radiologist using the low-cost portable V-scan ultrasound can generate images of breast masses adequate for accurate AI classification. Although specificity was less than with the standard of care equipment, AI applied to portable ultrasound can potentially reduce about half of the unnecessary referrals for benign lesions in these remote areas. And these were favorable results despite the lack of training of the AI with the V-scan machine. And we didn't show that the untrained observer could adequately produce diagnostic images, but that's on us. We should have done more than a 30-minute PowerPoint training. We could have spent the day with her going through palpable lumps and showing her how to take pictures, and I think just even one day would have dramatically increased. So basically, additional training with the healthcare workers, improved equipment. Now we have a better portable ultrasound machine and better training of the AI, and I guarantee this would improve the overall performance and allow effective triage of women with palpable lumps. Good. Any questions, comments? Oh, go ahead.
I think that this is really terrific. The question I had is, you said that you detected a certain amount of DCIS and a certain amount, I'm sorry. You said that you detected a certain amount of DCIS and invasive ductal. What about lobular?
We didn't have any patients with invasive lobular.
But can this detect lobular?
I don't know. I don't know. And the DCIS, and that was another interesting thing, the AI was never trained for masses representing DCIS. So if we added masses that were DCIS, it would really also improve the AI software.
What was the concordance between the radiologist and the V-scan in the missed cases? So that.
Oh, in this case, let me think. I think it was there were 43 cases that the radiologist called suspicious that the AI said were benign or probably benign. So I don't know, other than that, I don't know the exact numbers. So, good. Thank you. And thank you, Dr. Lau, for that.